Okay, great. Welcome to our AvaSure webinar, A Trailblazer's Road to Success. Today you'll be hearing from Beth Ackerson. She's a trailblazer for sure at the Cincinnati VA. And our webinar series is part of our effort to really create a learning community. Over the past 10 years, telesitting has definitely become evidence-based nursing intervention with plenty of published evidence. But after you've done your due diligence, you've done the lit review, you've read the published articles, it's kind of extra helpful to hear someone's personal journey about what they learned, what they did well, what went wrong. And so Beth Ackerson is being generous to share her personal journey with telesitting at the Cincinnati VA. She's the Chief Nurse of Procedural Services and Chief Health Informatics Officer, and she led the first implementation of telesitting in any VA hospital. And so now we're live coast to coast, from New York to California, down in Texas, up to Michigan. But Beth was the trailblazer, which is not easy and it's slower. And she's been very generous, not only that she put in that extra effort because of her passion for the safety of her veterans that are at the Cincinnati VA, but also she's been very generous to share what she's learned with others. And that's part of what she's doing here again today. So a few housekeeping notes. We have, I think we had over 170 registered for the webinar, so all lines will be muted, but there is a window that allows you to type questions, and we've left time at the end to field questions. And I'd like to draw your attention to avasure.com/events, and maybe at the end I'll talk a little bit about the upcoming regional symposiums when we'll be in your neighborhood, hopefully, and you can rub shoulders and do an in-person learning community. But I'm very excited to hand the controls over to Beth now, and she can talk about her story. So
thank you.
Yeah.
Can you hear me okay?
Yeah, I think we can.
Okay, great. Thank you, Lizbeth. Thank you so much for the opportunity to present here today. We're very excited about what has gone on in Cincinnati with the technology, and we're excited to share the improvements and some of the outcomes and some of our successes here. So as we talk about falls, we know that the falls are kind of the number one really on the radar screen across VHA. So we were looking at ways that we could really address fall prevention. And although we had a lot of really good evidence-based literature and a lot of good nursing practices in place within VHA, we still struggled in a lot of our organizations and a lot of our care settings across the nation to move the needle on fall reduction. So that was a major challenge for all of us, especially those unwitnessed falls. And as you know, the fall rate is anywhere from 1.3 to 8.9 across the nation. So, it's high both in our long-term care settings and in our short-term rehab, hospice, and also med-surg and critical care. And a lot of those falls resulted in injury, prior to going with the TeleSitter technology, which we now call in VHA, the terminology is a telecare companion, so it's really interchangeable. We know that we had a fractured hip here. We had some other major injuries, so we really weren't meeting the benchmark, even with sitters and bed alarms and all the fine nursing interventions that we put into place. And needless to say, the cost across the nation is very significant, $19.2 billion annually in the United States. And we were using roughly about, just to tell you a little bit about Cincinnati so we can put it in perspective. We had 74 med-surg beds. We have 21 critical care beds. And we targeted those two environments initially, and we were using about 5 FTEs of sitters. So we wanted to get those sitters away from the bedside, not so much in our, our suicidal or homicidal ideation patients, but there were a lot of times that we were putting sitters at the bedside and never going back to reassess. So the sitter sat there for the whole stay. So an average length of stay of 2 to 3 days may have a sitter around the clock. So, and the studies all demonstrated that there wasn't a decrease in falls, and we personally experienced that by placing more sitters at the bedside. So, when we started to do our research, we noted that there was a significant number of major healthcare systems that had incorporated the telecare companion into their care pathway. So, some of the background information is we pulled studies and looked at the evidence based literature. We realized that there have been significant reductions in falls and in falls with major injuries and minor injuries. And many places had the literature stated that there was up to a $2.5 million sitter cost reduction savings in 2 years. And on a brain injury unit, 80% of staff reported a positive benefit for themselves and their patients. And our nurses, the nurses were very upset that, the nursing assistants were sitting at the bedside. Sometimes we were still having falls even with them at the bedside. They, just to be honest, they'd be sitting outside the room sometimes. Sometimes they'd be on their technology. So we really wanted to get those nursing assistants back to the bedside, and that was a huge win and a huge satisfier for our registered nurses. So as we looked at sitter cost and how we could spread that sitter cost over multiple veterans, we began to realize that technology was truly the answer. So now instead of that 1-to-1 ratio, we moved it from a 1-to-12. We've even had as high as 1-to-15. And what I tell them is, it is difficult sometimes to watch that many veterans. So if they feel like they're getting into a place where there's a lot of admissions, discharges, or they have a veteran or two who's very, very requiring a lot of redirections, then, get another set of eyes on the camera. I'd rather have 2 people at a camera watching 15 than 1-to-1. So what we found too was that and I'll go into this more later in the presentation, but as we rolled out the technology, what started out as a fall reduction program really kind of morphed into some other applications for our veteran population. So we've really, the only time that we've had any negative veteran family experiences or any negative feedback is when it's not appropriately communicated or the veteran family are not thoroughly educated. So, but has anyone just refused the technology? No. And as I said before, the nurse experience was greatly enhanced. So as we looked at the evidence again, there were all kinds of studies out there about the return on investment. When we initially looked at our business plan, we felt like we could get a return on investment, just within the first 6 months, and I'll go into that more as well. Behavioral health, there's going to be some changes there. We have a couple of behavioral health beds, 3, I think that we call them our medical beds. So I'm kind of trying to get into that space with those beds to kind of introduce the technology and just do the visualization of the veterans. There were a lot of work violence clinical studies as well, and we have started to use that for veterans who are at risk for disruptive behavior. Some of the sites, that were in the literature as well: med-surg, critical care, rehab, oncology, long-term care, hospice, and behavioral health. And I'll talk to you more about how we've utilized them in almost all of those spaces. So the hardware, you really have permanent and mobile hardware. And what I've tried, we're working on a national contract here within VA. And so I've really tried to really pound the point home that we really need to have all types of hardware available to us, because what is appropriate for one space may not be appropriate for another space or an indication. So there are the mobile units, there are the ceiling mounted units, and there's also wall mounted units that I don't have displayed in the PowerPoint, but they're also available. So there's also the hub and spoke. So for those of you that are familiar within the VA of the tele-ICU, it's really kind of the same model that we could do within our VISNs and even across the nation, looking at all the different hospitals, CLCs, et cetera, and really looking at a centralized location. Now here in Cincinnati, I'm really driving towards decentralizing our program, because I really feel like the only way that I can truly get the best practice and make sure that all veterans remain safe is to have it decentralized and under its own manager with its own core work group. So that's what my latest business plan and proposal is on the table to the quadrant here. I cannot stress this enough. You know, those units who have strong leadership, who are out there, who really see the advantages of the technology and who are really drivers of innovation, those are the ones that you see on your report that, you know, they're finding new use cases for the technology, and those are the units that are have the highest utilization of cameras. So those are the units that you really want to showcase whenever you get the opportunity, so that they can spread their best practices across the organization. A lot of these tools that I have listed here, I have developed in a clinical reference manual. When we did our project kickoff, we had weekly meetings. I pulled in educators, NODs, the managers, and for some frontline staff, just for the weekly meetings. And then we set some of we talked about the expectations of the program. And then we did media releases. We of course have residents and attendings, and I met with all the physician leadership, and I sent letters out. I went to staff meetings. We had videos, and so I encouraged everybody to really, by the time AvaSure came on site, everybody was very aware of the technology, and most people had been educated to put the technology in use. And we talked a lot about best practice just across, not only within VHA, but across the healthcare industry as a whole. So the technology that we went with, we had a 46-inch monitor. We really like the sit-to-stand desk. We don't have that in our current space, but that will be something as I expand the program that we will definitely have. There is the ability to provide a privacy screen. There are scripted responses in multiple different languages. So when you need to get a redirection out there fast, we have the ability to do that. We're very fortunate here that we've been on Vocera, the telecommunication badge, since 2010. So it really was hardwired into our practice. So what we told the virtual monitoring technician to do was to broadcast to the entire unit, because when time counts, we can't be looking for the caregiver for that veteran. I want everybody on that unit to know that there's a veteran at risk. And then we also implemented the best practice of our nursing assistants being on 8-hour shifts. And our initial thought was that we would cross-train between telemetry and virtual monitoring roles. But the more we thought about it, and the more I'm driving to best practice, and after going to AvaSure Symposium last year, I really think we need to decentralize the program in order that we have people that really understand the technology and can get out there and educate at the bedside and deploy the cameras. So early on, I met, as I said, with weekly meetings with the managers, the NODs, and the educators, so that they would understand what their specific roles were. We also developed downtime contingency procedures, but I will tell you that we really have not had any unplanned downtimes. Probably the first week or two, we had a little bit of systems issues, but now what we found is working with the technical team is that if we take the system down at a dedicated time, which is Monday at 2, every week, that we have no problems. So we just take it down and immediately reboot it. So we've had no problems there. And then as soon as we decided that we were going to go with the technology, we got the health stream education out there, and then we did weekly monitorings on how compliant we were with the half-hour education for nurses and the 1 hour education for the virtual medical technicians. So we trained as many as we could prior to the visit. And then we also integrated the process into our new employee orientation as well as into the preceptorship on the units. One other key thing that I think has really driven our discharge process internally is I work with social work, and I even went with a social worker out to our contracted nursing homes so that they would clearly understand the technology, because initially we got a lot of pushback saying that no, we can't take the veteran because they're on a camera, and so their perception was that that was the same as a one-to-one sitter. So I had to go out and talk to them about the technology. We sent letters to the administrators of those sites, those contracted sites with us. And so we've really been able to turn that around. I don't hear that. In fact, if anything, I think they're entertaining the technology now. So it's really worked to our benefit to be able to discharge our veterans now that we're not providing all these one-to-one sitters. So we established all of our policies and protocols, worked very closely with AvaSure on that, and to make sure that we were in a really good place for best practice. And that's all part of the clinical reference manual, which I share with everyone on the both internal to VHA. I'd be more than glad to share it. And then also we have it on our nursing intranet site here. So if anybody has any questions or they have any technical difficulties, they can access that. So like I said before, what started as a fall reduction program quickly morphed into a lot of additional inclusion criteria. So in the morning, I go to every morning report. I ask a lot of questions about why veterans weren't on the camera, and should this veteran be on the camera, trying to get people to think more and more about what are the indications. So some of these things have kind of morphed out of those conversations. One of the things that I don't really see on here is we are using the camera as well for our total joints, for especially our total knees, because of those regional blocks. So we want to protect them, until the block completely wears off, because they feel really good and sometimes they have a tendency to get out of bed. But all of these things have occurred. So what's it used for? It's fall risk. A lot of those veteran behaviors, pulling at lines, tubes, property destruction. We caught veterans self-medicating. We caught a drug deal on camera at the bedside. And we're doing. I'm really trying to drive the point home that we need to put the veterans in MICU when we're, our ventilator dependent veterans, because we have a tendency sometimes to want to have a sitter there, and I'm really trying to drive their compliance with making to put a camera in the room. So right now, all of our cameras are the mobile units. So also, I want him to think about, what are those common conditions that we see and those common diagnoses with our veterans. So we see a lot of central nervous system disorders. We see a lot of TBIs, altered mental states, detox. Every veteran who is on our detox unit, which is one of our med-surg units, there we have some detox beds there. All veterans are placed on the camera. So anyone that has any kind of eating disorder, and then some dementia as well. So some of the things that we've seen as far as our feedback is our families really like it because they like the peace of mind of being able to go home and rest at night and not worrying about their loved one. So there's an extra set of eyes all the time. Um, we also had, of course, the continuous monitoring, and then we are able to protect more veterans and mitigate the risk. So our exclusion criteria is very clear in our standard operating procedure, our policy. Anyone that's at suicide risk and for our behavioral restraints or anyone who has failed the telesitter. And the good thing and what I have said to many people is that, many of the staff is that put the camera in the room because we are at least collecting some data. So we know how many times, instead of just saying, oh, we can't redirect that veteran. Well, can we? Or, is that your perception or is that validated? Where here we can collect data. And the failure protocol is clearly outlined there, and then it's also outlined some of the interventions that they can take in order to address that. So I also clearly outlined some of the clinical staff responsibilities. They and what we've tried to hardwire really into place is when a veteran's admitted, identify that veteran. When you're doing the admission history assessment and you see a TBI, put a camera in the room. So look beyond the fall score, the Morse fall scale. And then when they do fall, when they're admitted, look at some of those factors that we look for that make them high risk for falls and just go ahead and deploy the camera. So you can see there some of the charge nurse responsibilities are exactly to do that as they huddle, as they make rounds, as they're doing their RN to RN handoff. Include the virtual monitoring tech if they are on the camera. If they're not on the camera, make that a piece of your handoff so that we can more effectively identify those veterans. And really, the NOD is the main gatekeeper for the technology. So they're in charge of, the admissions. They get called all the admissions. And when all of our units are in use, they can triage those. That's when we go back and we look at those number of redirections to see, is there someone who maybe is more appropriate for the camera? And then we move those cameras based on the data that we've collected and the actual clinical need within our facility. So the monitoring tech, they receive the report from the RN, and of course they are the ones that get the information from the nurse. They log all the information. They redirect. What we want to see is a lot of redirections and a low number of alarms. We're not quite there yet, but we're working on that. And I want to see them, if they see someone who's in imminent danger, set off the alarm, broadcast on Vocera, so that immediately whoever is by that room can go to that room to protect that veteran. So we did there was a lot of go live support, and then by both the clinical and technical team. And then 6 months afterwards, AvaSure came back on site, and we did some mobile rounding. We looked at our education. We did some dashboard review. We've just recently got our ORNA data, which is our online reporting, our nursing analytics. So we have started to look at that and share that with our management team as well as our staff. And there's just constant conversation every day about how can we hardwire that into practice. And I'm always questioning, we have 15 cameras, why do we only have 12 in use? And it's not driven by census, it's driven by actual clinical need. Why do we, so there's that constant, they're like, oh no, she's in the room again. But there's that constant challenging of, let's don't leave the technology in the corner, let's protect the veteran. So with the ORNA data, we're able to look at our actual utilization. So it helps us with comparative data analytics. So I want to know, as a site, I want to be benchmarked against sites comparable to my size. And then how am I meeting the benchmark, and what opportunities do I have for improvement? The thing about ORNA is that it's the only database of its kind in the United States. So we can run reports on unit utilization, on alarm rates, on actual staff interventions, and then the effectiveness of both monitor tech interventions and the bedside staff responsiveness. And so also coupled this with my Vocera reports, so I can also see like when was that call triggered to the staff. So I can compare both databases to see, is that really happening as intended, as we have process flowed. So there's our actionable intelligent reports that we get monthly, and we're able to look at performance snapshots both by unit, hospital, monitoring tech, and then also we monitor our veteran selections. And it's always good to do a unit by unit comparison because that creates a little bit of competitiveness in the units. And then people talk about their best practice and some of the good catch stories. So there's some sharing that goes on there as well that's kind of facilitated by the data. So, what did we learn? We learned that being first was tough. The software had to be listed in the one VA technical reference manual. So, I had to work very closely with OINT and Biomed to answer a lot of the clinically related questions on why this technology would drive quality, safety, more effective care at the bedside. And so I selected a strong OINT representative to help me with that, as well as a biomed champion, two veterans who really understood that, keeping veterans safe while they're here is our first and foremost responsibility. So also, when our units were delivered, I don't know, somewhere along the way, I lost the memo, I guess, I thought they were wireless and they had to be hardwired. So we had to go back and retrofit every room. And we were deploying this in 5 units. So I said, let's do a real quick assessment. Where can we get this deployed, the whole unit first? And then we'll retrofit the rest of our units. And so that's what we did. I mean, it wasn't the ideal, but we managed from March of 2017 until October, and I had every unit live, so in about those 7 months. I always say that there can be no assumption about notification. So the communication between the nurse of the veteran who's being monitored and the virtual monitoring technician is critical. So make no assumption about that. You call them as often as you need to if you see something that doesn't look right. The one thing I will tell you about that is we did prevent a veteran suicide. And it was a veteran who had not been identified as a high suicide risk. And I always tell them it's a tool in your toolbox. So use the tool, use it effectively, use it when it's clinically indicated, but it still does not replace all the good nursing care. So, the idea of getting those nursing assistants away from the bedside is so that they do one-to-one rounding, they do toileting, because we have we have veterans who are left unattended. So, while they're in the restroom, all of those things need to be corrected. So there are a lot of nursing interventions in addition to the clinical technology. So it's a tool in your toolbox. And still predicting which veteran is likely to fall continues to be a complex challenge, but the staff are doing a good job of just identifying those veterans who are most at risk. So we, our veterans and our families, a lot of them didn't like the one-to-one sitter at the bedside. And they seem to think that the camera a lot of times is less intrusive than having someone sitting at the bedside. And like I said, the families are really satisfied with it because it relieves them from being that sitter and in that safety role. So, and the CNAs are available, and we really were able to decrease our cost of sitters as well as decrease our fall rate. So, some of our outcomes during the first 6 months of implementation, we demonstrated a 61% reduction in falls, and that was across our 3 med-surg environments and our 2 critical care environments. So, that was during our initial implementation. And our IPAC data, our fall rate per 1,000 bed days of care went from 3.11 to 2.08. So, we're really where we need to be as far as our NDNQI data and also our IPEC data within the Cincinnati VA. So we had 9 falls in critical care. We were able to reduce that to 1 fall in critical care from one fiscal year to the next. And as I looked at any time, bear in mind we only have 15 cameras, so that means we're not really monitoring probably to the extent that we could. But every veteran who's been monitored, no one has experienced an unwitnessed fall, which is good to report because that means that the communication's occurring as it should. And we've had no falls with major or minor injuries. Now, the one graph that was shared with me yesterday from the Community Living Center here, they came to me and, we were running, when I looked at the utilization, probably about 12 to 13 cameras, and they came to me and said they had a couple of veterans, really 3, that have fallen 5 to 6 times, and could we put it in the community living center? And the community living center was part of my expansion plan, but really didn't expect to do it right that way, but wanted to protect these veterans. So we went over, we assessed their environment, and we took mobile cameras over there, and we made that happen. And as you can see, those veterans were falling quite frequently. We were able to drive that down to 0 falls. And what we identified, we have 3. We have 1 north, 2 north, and 1 south. And 1 north was our highest fall risk because that's where those 3 veterans lived in our community living center. And so we've been able to really move the needle on that unit and overall make the CLC fall rate look much better. So there's also been overall, since implementation, a 17% reduction in sitters. But what you have to understand too is we had done some work to kind of decrease sitters by saying that, nurses were going up and saying, to physicians, order sitter. And so we drove that to a nurse driven decision based on specific criteria, and that criteria had to be it was a checklist, and that had to be completed every shift and turned into us. So we did kind of do some work preliminarily with sitters, but this has really moved the needle. I just want to share that I've talked to a lot of other sites within VHA that are using upwards to 20 to 25 FTEs per year in sitters. So the associated cost with that is quite significant because our nursing assistants are paid much better within VA than they are in private sector when you add up all the overtime that is paid as well as the benefits. And there are also some sites who are using agency sitters and who are going on diversion because of the lack of sitters. So those are all things that I've heard across the nation. So when you look at our ORNA data, this really shows our reasons for monitoring. And as you can see, I'm not really sure how that suicide precaution got in there as a selection, but the rest of them are very appropriate. We've used it for aggressive behavior. We've used it for those veterans who are at risk of elopement, and also for delirium restlessness. One of the real key populations that we've identified in our CLC are the hospice veterans at end of life, like the last 48 hours of life. They get that anxiety and become very restless. So I'm hoping in our future expansion that we'll be able to protect them most. But as you can see, it's 66% for our fall prevention. So over the time period of April through July, we've had 345 veteran admissions and discharges. And when I talked to our chief financial officer here, he said, really, when you roll it all up with benefit cost and overtime and everything we spent, he gave me $50 an hour. So when you look at our total monitoring hours and then you look at $50 an hour, you can see 1.5 million. So that's pretty significant savings that we're able to spread. You can also see down at the bottom that there are those units that they call the laggers in our critical care units. So when I call them out, they put a camera in the room, but we've got some work to do there with their adopting the technology. I want to talk a little bit too, just about before we open it up for questions about our expansion. So I told you we started with 15 cameras in med-surg and in critical care. The part of our expansion is, like I said, to decentralize the program with an assistant nurse manager for 15 nursing assistant FTEs. To all of our private rooms, we'll have ceiling mounted cameras. So we just put all private rooms on one of our med-surg units. So it will have all ceiling mounted cameras. That will free up our 15 mobile units for the other med-surg, the other 2 med-surg and critical care units. And then we'll be adding ceiling mounted units for all 48 beds in our CLC, as well as our 3 common dining spaces, which also cross over to our recreation room. So we'll be monitoring those spaces, and then also the 3 medical beds in our behavioral health unit. So that'll give you an idea of what our expansion program will look like here in Cincinnati. So if there are any questions?
Yeah, hi, Beth. That's wonderful presentation, and I enjoyed hearing about that and appreciate you being the first. And I guess since you're talking about expansion, there were a few questions along those lines, more at the enterprise-wide. So somebody wrote, is there a chance TeleSitter will be added to enterprise-wide initiatives that are available for office and rural health funding? And I think there was another question that kind of had to do at the enterprise level. If you were, VSO, did you plan, communicate your plans for telesending with VSO representatives? And some of these acronyms are unfamiliar to me, not coming from the VA setting.
Veteran service organizations, we sure did. They have a meeting here, and we did communicate with them. I also communicated with the unions very early on. We shared the technology with them, and the way I presented it was, it's going to free up nursing assistants to the bedside, so it's really going to help the registered nurses. Through National Nurses United, which was our union here in Cincinnati, and then AFGE, which oversees as the bargaining unit for our nursing assistants. I told, the way I presented it to them was, this is really an important skill set for nursing assistants to have, on their resumes, because remote care is growing so exponentially in the healthcare industry as a whole. So we are really helping them to gain a skill set that makes them very marketable, whether they stay within the VA or go outside the VA, because this is the way that healthcare is going in so many different arenas, not just with monitoring, in the telecare companion program. So they bought into it very easy. Now, what I can tell you is going on in VHA, they are getting a national contract to be able to for each VA to be able to get the telecare companion equipment. So that's still in process. I really don't have a date. They're saying 2020, but I know that that work is going on. So, as far as rural funding, I can't really speak to that, but I can tell you that there's going to be a national contract because this has been presented both to the Office of Nursing Services. So the Chief Nursing Officer is very aware of this. It's been presented to the Office of Nursing Informatics, and it was even a part of the technology modernization funding from President Trump at one point. But they felt like it really needed to be its own initiative that every VA would have access to and not go through that route. So that's the reason the contractual route, um, was
Okay.
decided upon.
Okay, thank you.
Hmm.
There's several different questions or people asking about consent/privacy. Can you speak to that?
Sure. No consent is required. We are not. We are not. We're not recording. So there is no consent. Education is required, extensive education, on the technology and how privacy will be provided upon demand. So if something's going on with that veteran where privacy is indicated, there's a privacy screen. The thing is, the staff have to be taught, when they leave the room, that the privacy screen has to be removed. So that has not been a problem at all. So once that's hardwired into your process.
Yeah, absolutely. And that is, I think, the case outside of the VA as well. And this is I think, a double whammy of a question and a really good one. First part was, how did you get nurse and leader buy-in? And then the second part is build relationships between the telesitting team and the bedside team.
Um, Nurse leader buy-in. I'm still working on that. I've got I mean, as you could see, the critical care still needs some work. For some reason, and I don't know if it's their ratios are better, so they don't feel like, the technologies is indicated. But I'm really trying, instead of putting someone in soft wrist restraints, put the camera on them. So I'm really trying to work with them. As far as the med surg units, there's still some room for improvement. I think the big thing is to just identify your champions. And like I said, every time you get the opportunity, I'll say, Noel on 5 North, wow, he's really rocking this data. What are you doing, Noel? Share your best practices with the group here. So anytime you get that opportunity, I capitalize on it just to try to get everyone on board.
I couldn't agree with you more. That it is one of the benefits of the ORNA database, is being able to use transparency in data to kind of drive best practices like that. Do you, and I feel like you mentioned a couple good catch stories, and I feel like good catch stories can be kind of qualitative data that also improves buy-in and even that relationship between bedside nurses. Do you have any examples of good catch stories that you used in that way?
Yes. We have, like I said, we prevented a suicide. Um, that it was caught on camera. The veteran was not at risk, had not been identified as a suicide risk, and was taken a phone cord, which was very significant, probably our very best catch story. We've also had other good catch stories. We caught diversion. We caught another veteran being an inpatient veteran. Medications. We caught veterans taking medications out of their backpack and self-medicating. Um, we There was an O2 sat that had dropped down into the 80s, and the nursing assistant immediately contacted the nurse. Caught that. We caught an anaphylactic reaction on camera. So those are just the ones that come to my mind immediately.
Wow, amazing. And then just kind of one more final question on the theme of buy-in. What are your suggestions for pushback from the medical group?
I think the sooner that you can get awareness out there and meet with those groups and let them know that, that we are going to be implementing this technology. We really need you to help engage in this and support this technology at the bedside. In fact, now I have residents saying, can we put the camera on this veteran? So they start embracing it and engaging and deploying the technology for you. But I think early on, just that continuous awareness and immediately tell them, this does not require an order, and this is what we're seeing. Share the evidence that's out there about these are the best practices with this technology across the nation. Why wouldn't we want this for our veterans? I mean, this just really makes sense for our veteran population and all the indications. Um, I I really can't say that I had any problem with medical staff buy-in. I mean, they really embraced it, and they liked the fact that staff were going to go back to the bedside, too. So I can't really say I had any negative. As long as they're informed and they're educated and they realize that, this isn't going to create any extra work for you, we're just going to make sure that our veterans are even safer than they are today.
Yeah, I agree. And I think what I've seen that is very effective also is to share those really strong peer-reviewed journal articles that demonstrate the efficacy as well.
Right.
We have a few questions about kind of the staffing. The first one is, are the individuals monitored by VA staff or a third party?
VA staff. Right now, the telecare companion program is under the auspices of one of my med-surg nurse managers. But like I said, I want to decentralize it, and I've identified space here in Cincinnati, and I want to hire additional FTEs that are dedicated to the technology only. So they're not floated in, because that's that's the thing that kind of bothers me. It's like, well, who's on the camera, today? And sometimes I don't think it's taken as seriously as it could be. So to drive the best practice, I really feel like I need to decentralize it. But right now, it's part of the staffing on a med-surg unit. It's
Yeah, and
incorporated.
I agree that that leadership, that person who is the manager of the telesitting monitoring tech staff has to be a really strong manager to make sure that holding them accountable for their safety role. And just one more question kind of along those lines was, what is the patient ratio, number of patients to monitoring staff that you use? And where did you get?
I know they always try to pin me down to a number, and I tell them that, the literature says 1 to 12, 1 to 14, but that doesn't mean that we can't go up to 15 if if they're sleeping all night and we're just monitoring them and we don't have a lot of turbulence and veterans being admitted, discharged off the camera or whatever, then, that may be very manageable. But I've always asked the NODs to round on the virtual monitoring tech and ask them if they're okay. And if they're not, deploy another asset there. Because I'll hear them say, oh my gosh, we were so busy with 1 to 10, but then another day I'll hear them say, oh, we were managing 1 to 14 just fine. So it just depends.
It really does. And you mentioned earlier the quarterly reports that you get from the being a participant in the ORNA database. And that's one thing that we noticed when we're looking at the big data from hundreds of hospitals and millions of hours, that certain patients are busier than others. And those detox patients are way up there at level of busyness. And then some of the other types of patients are busier at night and others are busier during the day. And so being able to shift to the need rather than having a rigid number probably is the best use of critical thinking and best use of most efficient use of the resources.
Correct.
I think I've got the questions are coming in faster than I can read them all. So, um, good morning from Canada. That was a nice question. Um, but I think that I'm seeing themes, and I think, oh, here's one, um, and I wanted to talk about this too. Can help me understand the $50 per hour. And I think even if you had talked that your CFO was including overtime and agency and benefits and all types of other costs, but at other places in the country or outside of the VA, that hourly cost could be a lot lower, but at the same time, this is only 4 months. And so I think if one was multiplying this by even $20 an hour, there would still be a very strong ROI with it. But do you have anything else to add to that question that came up about the $50 an hour?
No, the only thing I can tell you is that, like a lot of places across the country, we had a high vacancy rate. So we were using, there were some of our nursing assistants, we were driving up significant overtime costs. So when you factor in all that overtime cost with the benefit cost, with the nursing assistant salary, because I know here in Cincinnati, sometimes the nursing assistants are making as much as a new grad nurse out in private sector.
Wow. Wow.
So our
Okay.
nursing assistants are paid pretty well here.
Okay.
So, and the first 2-3 years that I was here, kind of boots on the ground, I managed all the staffing and trying to pull, because I'd have to pull from multiple areas. So, a lot of times, every nursing assistant that I had in house was sitting, or they might be from the lab, they might be from transfer. I was just pulling them from everywhere, um, even if they had transferred out. So our overall costs was really high because
Yeah.
those were all overtime dollars.
Yeah. I remember using labor and delivery nurses, highly skilled labor and delivery nurses if the L&D was quiet as sitters. You just have to get creative if you don't have the technology to help out with that. We had a few questions about suicide ideation that I would like to address. The Joint Commission in May came out with an FAQ stating that for patients who are not high risk for suicide, that video monitoring is up to the discretion of the hospitals. And there's Harvard psychiatrist did a study on video monitoring for suicide risk patients, which was published in January. And these are and so we do have many hospitals that are using it for suicide risk, although that's not a Cincinnati VA inclusion criteria, and certainly not for the highest risk. And so that is like an example of one of the conversations that we'll be having at our Midwest Symposium and Western Regional Symposium coming up in September and October. And so we're just trying to continue to create that learning community where you can, sit over lunch with someone like Beth and learn what they learned and their outcomes along the way, and some presentations and some roundtables. And Pat Quigley Dr. Pat Quigley is a fall prevention expert out of Vision 8 for many years. Just nationally renowned, and she's going to be the keynote speaker at both of these symposiums. And I think she's on the line now, and she's muted. Otherwise, she would be just saying, "No, Lisbeth, I'm just a nurse that won't give up on falls." So, anyway, Beth, you probably heard her say that before too. So we're looking forward to more webinars coming up. Beth referred to a decentralized versus centralized, and across the country we have all different care models, and some have a hub where they're monitoring all the patients in the system in the whole state, and beyond. Some are monitoring patients who are in a different time zone, and then others do something more decentralized out of a single hospital. So that broader hub and spoke model, we'll have a webinar coming up October 23rd, and also workplace safety is coming up. So Beth, thanks for being generous, not only about being the trailblazer, and you said an understatement that it wasn't easy, and you learned a lot along the way. And so thank you for that. And thank you for not only blazing a trail, but holding up a light for those coming behind you on this as well.
Oh, you
So
are so welcome.
yeah. And Ava prize winner last year too. I forgot to mention that.
That's right. That's right here in my office, actually. Thank you.
Okay, so
Okay.
thank you all for taking the time to learn a little bit more about something that can really improve your patient's safety. And I hope everybody has a great rest of the day. So goodbye.